You know what? It's 8:30. Good morning, everyone. I've got a couple more people joining. I'm going to give it just a second or two, and then we're going to start. Okay. Well, good morning. Happy Friday. Thank you guys for being here on a Friday during the summer for this great session that we have with Connie Bonebrake, the strategy lead at Humana, and also one of our amazing coalition members. Just a few quick notes before we get started. Just a reminder, please make sure these Friday Facts sessions are on your calendar. We have some really great sessions coming up. You can see the schedule on our website, and the sessions occur the second and fourth Friday of each month at 8:30. Also, our monthly meeting is next Friday, July 21st at 11 a.m. So we'd love to see you there for that as well. Last thing I have for you is just please say hello in the chat and introduce yourselves and your organization and any questions that you have. And with that, I'm going to pass things over to Heather and get us started.
Well, good morning. Hello, Coalition. And this is great. What a great group of friends I'm looking at on this lovely and super rainy day here in Chapel Hill. Connie's in Charlotte. It hasn't started raining there, but I know here in North Carolina, we're having kind of an interesting day and so fun to see all this excitement. The chat's already blowing up with all these hellos for Connie. Connie, you've got a fan club.
I've got friends. I have friends. Yes.
Well, all right. So, but I'll do the introduction. Connie Bonebrake, it's so nice to have you here. We are excited to talk with you. We have a lot to get into as you are the population health strategy lead in the Southeast region of Humana Health Equity and Social Impact Group. I don't know if we've spoken to another insurance person before. I haven't, so I am all excited to get up into your business. But as we do here at Friday Facts, before you talk all about your health equity and social impact work with Humana, tell us a little bit about yourself, where you're from, and what motivated your career turns.
Sure. Well, first, thank you for having me. And I see so many faces that where our paths have crossed through the years. So this is a great reunion of sorts for me. I'm actually from Brevard, North Carolina, in the mountains, which is the reason I talk the way I do. And, you know, I married a Hoosier, so I spent a few years in Indiana trying to downplay my Southern accent, but it didn't work. And then when we came back south, it's just as Southern as it's ever been. So that's where I'm from. When I was 15, I started volunteering in a nursing home. And I discovered there my passion. And I would say as a person of faith, I think it's my calling really to be an advocate for older adults. My formal education is in social work, and advocacy is a really good social work term. So when I went off to college, I thought I was going to be a nurse. And I have since worked with thousands of nurses. So I love nurses, but I really thought that's what I wanted to do because that was the only profession I had interacted with in the nursing home. And when I got to East Carolina, I decided I hated chemistry. So I decided that wasn't the path for me. And my parents had cared for foster children when I was growing up. So I had social workers in and out of my house all the time when I was growing up and admired them and had such great relationships. So I did my research and decided there was a place in social work for working with older folks. So I got an undergrad at ECU and a master's at Chapel Hill, all around macro social work and aging. And, you know, when I look back over, now it's been like 45 years of a career, I kind of think about it in 4 seasons. The first season, which I see Lee Dobson and some others that I knew during that first season, I was deeply in the operations of healthcare delivery to older adults. First as a nursing home administrator, and then as a leader in a larger post-acute division, which had home health, hospice, DME, home infusion, and skilled nursing, of course. So I learned all of those operations, worked with some great folks as teammates. In the second season, I was blessed to be a chief patient experience officer, and that role, I again learned so much, and it was all about listening to the voice of patients and families. That's where I came across Sue, and encouragement to providers and teammates really all the way across the continuum, to communicate with patients and families in ways that they can understand and act on. I thought I was going to retire from that job, honestly. And then, like so many others, I experienced a job elimination, and I had the gift of time to think about what I was going to do in my next season. I had a few years in the nonprofit world. I was a volunteer board chair of a small nonprofit that provided transitional housing for survivors of human trafficking. That'd be a whole nother episode. But then I was also an executive director of a nonprofit physician practice, caring for only individuals with dementia and Parkinson's and families and their caregivers. That role really helped prepare me for my own journey as the only child of a father with dementia. I think maybe like all three of those seasons, healthcare administration, listening to patients and families, learning about community-based nonprofits, all of that has prepared me for the work that I'm currently doing with Humana.
Wow, that beautifully said, because you and the others know that I stalk our guests, which is another way of saying research. And I have been amazed as I looked at your background and read your bio that you've had these interesting twists and turns. All connected in the healthcare system, all connected in some way to advocacy with seniors and their caregivers. But I love your way of talking about it as seasons, and as the seasons develop and mature and change, but there's some continuing threads. So, and I did note that you went from the administration world and from nursing home to integrated health delivery system, physician practices. So then what motivated, clearly you're still ready to work and bring in a paycheck, but that change into the payer space, I'm fascinated by as that next season.
Me too.
How has that gone for you? And
I can tell you, I never considered it ever. And when I was in that year of discovery about myself, one of the things that I was coached to do was talk to people across my career path that I had worked with, who might know, what I should be doing next. And so I was actually talking to a physician that I had worked with, a gerontologist that was, he had been at Cleveland Clinic. I'd tried to recruit him to Charlotte, but anyway, we had kept up through the years. And he said to me, "You should go work for Humana." And I said, "What?" Like, why would I go to the dark side of the payer, world?
I almost said you went to the dark side, and I didn't, but yeah.
But I learned from him originally about, first of all, they had just purchased Kindred, which is, the largest home care provider in the country. And at that time, he knew me as a home care professional. So, that was sort of the angle that I thought I was going to enter Humana in. And then as I researched Humana, I learned about their work in this health equity space, and it spoke to my roots of advocacy and population health. And there wasn't one of me in North Carolina. So honestly, I started banging on the doors of Humana saying, why are we not focusing on this topic in North Carolina? And I live in Charlotte, and we've got big payers that providers that I have relationships with and can partner with. And so anyway, it was time for somebody to come do this work in Charlotte, and I was blessed to talk my way into it.
Well, I'm so happy, and we do say lovingly it's the dark side, but it's actually one of the, there's so many important sides. I was going to say one of the most important, but there's so many important sides to healthcare, and right now how we pay for it links directly to how people have access to care. And that's so much that I want to dive into with you around equity and health equity and your work around social impact. And I know that you're making a difference because we've met some of the folks that you make a difference with. How's that interesting grammar? I'll just stop there and say, tell us about your work. And it really pulled you into Humana. Tell us about the health equity and social impact section. what their goal is, and what your goal is as the population health strategy lead.
Sure, I'd love to do that. I'm going to start with just a little bit about Humana because, like I said, who knew? I did not know anything about Humana. So let me just start with that. I started with Humana in 2020, and the company has really matured a lot, even in that short period of time. Humana is a national company. We're based in Louisville, Kentucky, and we have two kind of primary businesses. One is insurance, and that's probably what you all are most familiar with. And we have over almost 6 million Medicare Advantage members across the country, about 400,000 in North Carolina. And in North Carolina, we just do Medicare Advantage. In many states and growing, including South Carolina, we also are a Medicaid provider. We've got about 1.5 million members in Medicaid. And then an interesting thing that I'm very proud of and did not know until I joined Humana. Humana has the contract with the National Department of Defense, and we are the insurers for active military members and their families. So we have a deep appreciation for obviously active military, but also veterans. And there are individuals that do my role that work specifically with active military, and another young woman out of California who is married to a service member who works just with veterans. So there's that part of the company that's insurance. And then we have a patient-facing provider part of the company, which is growing. We have 250 senior primary care practices across the country. By the end of the year, we'll have 7 or 8 in North Carolina. I mentioned home health earlier. We've got about 820,000 home health patients that we care for. We're also a really large PBM pharmacy. So we've got Part D pharmacy. So with all of that footprint, I'm part of the health equity team, and we try to say grace across all of that part of the organization. And I don't think this will be no surprise to anyone. When you look at the literature, it's really clear that 60 to 80% of health outcomes are due to things other than clinical factors, which what makes this the heart of a social worker thing is that we know that healthcare and health outcomes are determined by things like what we call social determinants of health. So there's determinants that are upstream, like poverty and racism, and then there's midstream things that happen in our communities, like food insecurity or unsafe housing, or the digital divide, which we're spending some time in. I'll be happy to talk about that in a minute. And then there's, health-related social needs of members individually. What are the outcomes of those determinants? Things like obesity and heart disease and asthma in young children. And so what we seek to do as a health equity team is to eliminate barriers. Health equity is all about influencing and enabling the healthcare system. And that's not just payers, that's providers, payers, community-based organizations, so that every person, regardless of their race, ethnicity, gender, circumstances, has a fair and just opportunity to help. The role of the team, first of all, is internal to Humana, and that's a big job in and of itself. We have a mission to make sure that health equity is a key business driver for us, that it's a key cultural driver for us. I spend a fair amount of time inwardly facing at Humana, making sure, our employees have the tools that they need to interact with our members in culturally competent ways, that our frontline workers in healthcare are also equipped and are able to listen and communicate in ways that they can understand and act on. And then, what benefits are important too. we have the health equity team, not me personally, but there are individuals who have a lot of influence on benefit design. Humana was the first in the country to offer a healthy food card. And I'll be proud to say that idea and all the research and background and pilot work happened out of the health equity team. But now we're moving towards a more flexible spend. In North Carolina, for example, we have it on our DSNP plans, which is our dual eligible plans. Members have allowances anywhere from $35 to $275 a month, and they can use it for all kinds of things. Groceries, of course, over counter. They can also use it for things like, you know, non-medical transportation. I mean, how hard is that to find and pay for? And even pet care. So, you know, we appreciate the fact that, you know, folks are oftentimes dependent on their pets for that social interaction and that sense of safety, and so they need to be healthy too. So our benefit plans are constantly being redesigned to try to help elevate the social aspects, whether that's food or transportation, social interactions of our members. I'm gonna take a breath.
Okay, take a breath. And it's funny.
I'm talking about what I do.
No, you take a breath, and I look
Sip of
away just
coffee.
to sneeze. I took this all in. You know, I am loving so much about what you are doing, and you referenced a little bit that I saw, well, a lot of it in your vision statement, and I wanted to read it to the group, because your vision statement for the work that you're doing, and I love that you talk about the work that you're doing both internally, and I wasn't sure what that meant, so I'm glad that you defined it, internally to help the other employees do the work that they're doing, eliminating their barriers as an employee and doing good work in Humana and setting up, and then externally with the benefits that you're creating for your members. So it said your vision statement, or for the health equity, influencing and enabling an equitable healthcare ecosystem so that every person has a fair, just, and dignified opportunity to reach their full health potential. Now, I wish people I should have it up there, because I actually underlined 4 different parts of it. That is a complex, you know, vision statement to unpack. You talked, you know, so I'd love for you to dive deeper. There's the influence and enabling part, but then there's also, what does an equitable healthcare ecosystem look like, you know, to Humana and to help people have their full health potential? I mean, it's a great statement, but I love the different ways you're trying to work at the patient level, midstream, and then I'd like to hope that upstream as well. So,
Right.
Equitable ecosystem.
I'll do my best, but let me first say that in early 2020, what year is this? 2022, I guess. We hired a chief health equity officer, Dr. Olaiwala, out of the Ohio State University system and healthcare system. And she is a phenomenal leader. If you do not know this woman, you should follow her on social media and look her up. She is really the vision behind that statement that you just read, and our strategy. She's got a great team around her, but you know, we all know it's about leadership, and she is a fabulous leader. So now I've forgotten your question, but
well, I was
about it.
About the healthcare ecosystem and that vision and what's the doctor's name again, so I can follow?
Olaiwala. Her name is Nawanda Olaiwala, and in a minute I can type it in, or we call her Dr. O, so my Southern accent doesn't say Olaiwala very well. But she's great. And she's going to be in Charlotte, by the way, August the 23rd at a digital equity event I was going to plug here in a second, but love to have y'all. So let me just start with this. We have a ton of data. I mean, you know, if we've got 5 million Medicare Advantage members across the country and 400,000 in North Carolina, we can get pretty granular on looking at our members, you know, both as populations, but also as individuals through our provider offices. But in looking at the data, you know, the work to be done is clear. for example, you know, we know in our members in North Carolina that if you're a person of color, you're much more likely to have diabetes, cancer, hypertension, and you're much more likely to be living, you know, in financial strain, food insecurity, lack of support. For example, 12% of our white members in North Carolina are food insecure. 25% of our Black members and 26% of our Hispanic and Native members in North Carolina are food insecure. So because we have such robust data, we can use the tools that we have. You know, I can dig geographically into zip code level information about our members. Where are they? What services do they have access to? Where are the gaps in those services? And, you know, Humana can't be everything for these patients. So it becomes my work and the work of others to, you know, look outwardly and say, who in this community is doing this work that we can partner with? We contract with almost every provider in the state. So you know, what's this particular provider doing in this space? Are they screening for social determinants of health? That's the first thing we ask, you know, and if they are screening, do they know what to do if the screen is positive? Are they able to use a platform like Unite Us or Find Help to refer folks to the resources that they need? So there's a start on answering what we do.
And that's amazing. And I want to link into an observation I'm having and a question that Sue Deaton has, which is, that's amazing that you're asking, that you're doing those kinds of screens, that you're even asking that then you can use your data to identify who is food insecure. And it leads then to Sue's question, how can we ensure that the patient, family, caregiver voices are heard, so that, you know, I took it from the individual patient experience and know what they're going through. But Sue's question's broader. How do we make sure, because you have experience as a patient advocate, and now you're on the payer side to really make things happen?
Yeah. Oh, Sue, all of those you know, systems in place that we used on the healthcare side around surveying, and in this part of the business, we use net promoter scores and net promoter score pluses, which is all kinds of interactions that happen at the point of contact, particularly with like our call centers. Humana has really high net promoter scores. We really do spend a lot of time, not that we're perfect at it, but at that education of those people that are at the point. Because particularly on the insurance side, you all know how confusing all of that can be. And we have to listen to what is causing stress and concern with our members and try to respond. We also, you know, I mean, I try to be out in the community with just my ears wide open in places like this, in places like where Venitra works. You know, I'm so glad y'all talked to Venitra last week. Venitra's doing such great work at the Frankie May Foundation with groups of caregivers. She mentioned men and you know, obviously the community in which she lives and works, and are people that may not have signed up for a support group at, you know, Myers Park Presbyterian Church. So you know, we try to listen to people with lived experience, let them be the trusted voices in the communities, and just support them in their work as being trusted voices in the communities where they live and work and play and worship.
Well,
did that help?
It does help, and I'll continue on. Sue has another great question in the chat line, and it links back to something I was wondering. Again, I'll kind of infuse my question and Sue's together. Sue was curious, how is Humana showing the financial benefits of focusing on health disparities and inequities? ROI, return
Oh,
on
that's a great
investment,
question,
is
Sue.
so important to convincing leaders. This is important financial, social, and personal focus. So, and my question would be, what is the responsibility of healthcare, health insurance to take on some of this work? And so clearly, if there's a financial incentive, you know, how does that work as well?
That's a great question, Sue. And I will tell you that Dr. O is all over the need for us to continually mature our ability to measure our outcomes. And I would say that we are in the toddler phase, perhaps, of that. But in theory, here's where we're going. You know, if people are living there, if people are ultimately healthy, then they are going to show up less in the emergency department. They're going to show up less in acute care facilities. Those disparities, you know, ultimately our goal is to reduce those disparities, like in prevalence of diabetes, of hypertension, of cancer in between our white and members of color. And in reducing those disparities, we reduce the healthcare spend. And if we reduce the healthcare spend, then the Medicare Advantage plans of the world, you know, it makes their business flywheel turn. So clearly, you know, it's a philanthropic calling, but it also makes good business sense on the payer side.
Mm-hmm.
Did that answer the question?
We've got a few minutes left and the questions are coming in. So I'm just going to rapid fire some of these. Let's see. Our friend Lee has asked, what is the best way to create avenues for open discussion with clients and caregivers?
I think it's just, you know, I don't know. For me, it's all about relationships, and it takes a while to build relationships, but I'll give you an example other than Venitra. Through the congregate meal site program in Mecklenburg County, I was introduced to an African-American church that has a nonprofit called Intergenerational Resource Hub. And we have grown a really rich partnership with that congregation because they have already developed relationships with their congregants. And so we're helping support them on the backside with things like diabetes education classes. And, you know, they have health fairs that I help them organize because I know healthcare providers in Charlotte. So it's become a collaboration where, you know, what the voice of the end user, the patients, are coming to us through our partners in hard to reach communities. Mm-hmm. So that's definitely one way. I only have 1 minute, so I want to say this really quick. On August the 23rd, when Dr. O is going to be here, we're going to have a panel that's going to be facilitated by the Center for Digital Equity out of Queens. That session is going to be at the Betty Ray Center in Charlotte, which is, we picked it specifically because it's smack dab in the middle of a Black and Hispanic community where there's 500 seniors that live within a very short distance of that community center. We're hoping to have a community forum where we can hear from the seniors at facilitated tables about what are your issues with access, and access being digital, but also just general access to healthcare. We're calling it Stay Connected. It's good for you. So that's August 23rd, but that's another way of getting to know the needs of our patients in the community, is just listen and create spaces for them to talk.
Well, and that's wonderful. And you can send that information via email, and Virginia's already nodding her head. She sends great information out. I'm moving quick here because I know we just have a minute. You actually kind of halfway answered, or maybe full way. Keith Steyerwalt had a question about your connection with the faith communities. The second part of his question was, does your organization work directly with faith communities? I think you just gave an example. Yes, you do. Do you gather any research, to go to the first part of Keith's question, if you see it in the chat? do you have any research that demonstrates the positive effects as you're screening your members, be those that are part of a faith community? Have you seen any positive effects with that connectivity?
You know, I don't know about direct research related to the faith community. I have all kinds of anecdotal stories. My partner city in the Southeast is Atlanta, and in Atlanta, our biggest partner is Ebenezer Baptist Church. We do tons of stuff in Atlanta with Ebenezer Baptist Church. So, you know, yes to the importance of the partnership. Yes to anecdotal evidence. I'm not sure that I can point yet to outcomes related directly to faith communities, but we know that, you know, finding wherever the source of trust is in a community, and oftentimes it's places of worship. It can be other places too.
Well, I know it's crazy. I know we're out of time, but I don't know if we've blown up the chat line as much as we have as we're doing right now. And I'm also getting all these direct messages. Connie, there's it wasn't quite a question, but you, as we turn to the coalition and your wonderful work with the coalition, because you've been an active member for a while now, as we think about the coalition's efforts, especially around health equity, curious about any advice you have for us. But also there was a question, are there other Connies at other health insurance groups that we can bring together a panel and start to help to influence and enable more organizations to try to limit the barriers and open up opportunities the way that Humana is? So I know we had talked before.
There are.
Talk about yourself, but can we bring you and can you clone yourself to the other providers and payers and have a discussion?
Well, fortunately for everyone, there's no more Connies, but there are people who do this work with other providers. So yes, I'd be happy to help figure out who are my peers across other payers. And even if it doesn't sound exactly the same, I am confident that other payers are paying attention to this social determinants of health space and may have a different strategy that we could all learn from. Yes.
All right. Well, I hate that
there is no right one way.
This has been so great. And I'm already, my wheels are turning. I know that a number of the members are, and we have our symposium coming up. So I think this is the first of more panels and discussions we're going to have with you, with Connie. And I know you've been just a really great member of the coalition. I am thrilled to be able to have a little bit of a spotlight on you and your work. And there's a lot more to discuss, but we'll close it for now. Maybe we'll have a part 2 with Connie. Connie Bonebrake, thank you so much for joining us.
You're welcome. Thank you.
All right.
I'll have a blessed weekend.
Yes,
Bye-bye.
happy Friday, everyone. Thank you.